Very good afternoon, everyone. So, I'm going to talk about breakthrough in pediatric retinal imaging, rather expanding the platform of MIOCT to pediatric patients using exo-illumination technique. So, as we are aware that optical coherence tomography is a vital diagnostic and a therapeutic surveillance tool for wide spectrum retinal choroidal pathologies. Conventional table-mounted OCT are not designed for infants or young children. Portable handle OCT, although designed with appropriateness for infant and children, suffers from problems like image loss, and there is additional high equipment cost. MIOCT is now becoming a very important intraoperative armamentarium for retinal as well as anterior segment surgeons, but requires invasive ocular image requires invasive intraocular illumination for image acquisition. Can the benefit of the MIOCT be transferred to these uncooperative infants and young children without the need of invasive intraocular illumination? That was the question we need to answer. So this study describes and assesses the efficacy of exo-illumination MIOCT technique for non-invasively obtaining retinal OCT images in children undergoing examination under anesthesia. So this was a prospective study, observational study carried out at Advanced Eye Care Center, PGI Chandigarh. 10 consecutive pediatric patients with suspected posterior segment pathology, uncooperative for retinal choroidal imaging on conventional table-mounted OCTs were taken into the study. The outcome measures were total image acquisition time, that is the time from the beginning of the OCT machine, the switching on the OCT imaging, and till the end of the procedure. A second outcome measure was successful acquisition of interpretable vitreous retinal choroidal OCT images. So how this was done? So what we did is we used a simple endo light. We placed it at the limbus. The light passed through the cornea lens and reached onto the disc. Once the disc was visualized, we switched on the MIOCT machine. The MIOCT machine was switched on. It could visualize the disc. We optimized the layers of the retina with the inbuilt optimization software. Once the disc image was achieved, we moved the crosshair to the area of interest, and this is how images were achieved. So different size scans were used, and they were all recorded and compared with each other. Two different surgeons performed the same procedures so that we can observe the intra-observer variability. MIOCT, which allowed the delineation of all the structure, all the layers of the retina, were considered as good quality scan, while those in which the layers could not be delineated was considered as inferior quality scans. So both the surgeons could delineate the foveal microstructure in all the 10 eyes using our novel exo-illumination technique. All images acquired had a good spatial resolution and were good quality images. However, I would like to inform that the exo-illumination technique did not work in one case that had X-linked retinoschisis with inner retinal equatorial break. So any lesion which was at the equator or beyond that and anterior to that could not be scanned with our technique. So this is the list of patients. So optic disc, fovea and parafoveal microstructures were best seen with 4x4 mm scan, while 16x16 mm scan were used to localize the area of interest as well as allowed us to give us the overview. So look at this image. So what you see is a pediatric patient that came to us with an RD. We use the exo-illumination techniques, and we know that patient has an RD clinically, as well as we can quantify the macula is detached. The same patient underwent buckle. During the buckling, when we did an SRF drainage, initially we know that this is how much the fluid is left. We drained him further, and then we intraoperatively, without going into the eye with the help of the endolight, we could see that the retina is well approached. The total time taken in this procedure by both the surgeons was around 3 minutes 25 seconds roughly. And how this, the conclusion for our study is that exo-illumination technique can effectively provide invaluable microstructural information during EUA and can augment the findings obtained by clinical examination of the pediatric patient. This technique expands the platform of existing MIOCT indication, preventing additional expenditure required for an headlamp OCT. However, we need to understand this machine also has a limitation of conventional OCT, that is, we cannot image beyond the equator. Thank you.
So by manipulating the eyeball also you could not image the area beyond the equator, or could you?
Ma'am, so what happens is that whenever we manipulate the eye, there's a diffraction of light happening. So diffraction of the light loses the image quality. If we could do this, it's just the same technology. So if you try to, if you try to take an image of an infant on an Optos or an OCT, and you try to give him a face tilt, your image quality goes down. So although you might get a fundus picture, but you will not get a good OCT. And OCT is good enough only when it gives you complete spatial resolution of layer by layer. So you might get an image, but can you identify the disease is the question.
We could not see your OCT machine in the photographs you have shown.
Yeah.
Which
Yeah.
machine you have used?
So this was a Zeiss microscope resight. The machine that is used in this study was the Zeiss with the resight. Resight is the intraoperative OCT of the Zeiss.
It's
with the
integrated,
just-
yes.
just-
You have not shown it.
How'd you say?
But your pictures didn't show it.
Uh,
The
Okay.
resight is the
Commercial
viewing
interest
system. What is the OCT? The resight is the viewing system, right? So the OCT is
ma'am,
integrated.
I think this is incorporated
Is
to
integrated
700.
into
Yeah.
that
Yeah.
viewing system.
It's a Lumira 700 system with
Yeah,
inbuilt
with
OCT and the
inbuilt
resight.
OCT, yes. Okay, and what was the general anesthesia or ketamine or what? did
Ma'am,
you
it's for
give?
GA. All the patient
Full
who see,
GA.
yeah. So
it
basi-
just took 3 minutes, so you could just have given a short acting ketamine or something.
So, ma'am, what we were thinking is that this study was done in PGI. PGI still don't have an handle OCT, additional expenditure. Even it's a top tier institute of the country. So, how can we expand the platform? We had an MIOCT, AIMS has an MIOCT, PGI has an MIOCT, many other institutes has MIOCT. Sir, this was part of the EUA. So this was
Okay.
not, we did not do an OCT per se.
All
A
right.
EUA that was being done, we just did an OCT.